Hello, I'm Eric Strong, and I'm a clinical associate professor of medicine at Stanford University. This is the second video in this series on the respiratory system. By the end of the video, you'll be able to describe the lobar anatomy of the lungs and their fissures. You'll be able to explain the branching pattern of the airway tree, to identify the layers of the pleura and describe the pleural space, to compare the pulmonary and bronchial circulations, and to list the primary and accessory muscles of respiration. The lungs occupy most of the thoracic cavity, sitting on either side of the mediastinum, which is the central compartment containing the heart, great vessels, esophagus, trachea, and some lymph nodes. The lungs are divided into lobes separated by fissures. To see how these lobes and fissures relate to one another, let's look at the front and medial faces of both lungs together. The right lung has two fissures, the horizontal fissure and the oblique fissure. This separates the right lung into a right upper lobe, a relatively smaller right middle lobe, and a right lower lobe. The left lung has two lobes, the left upper and left lower, separated by the oblique fissure. The left upper lobe has an additional tongue-shaped projection that wraps around the front of the heart called the lingula. The lingula is homologous to the right middle lobe, but it's smaller and not separated from the upper lobe by a fissure. This asymmetry allows space to be occupied by the heart. A quick note about the orientation of the lobes. The oblique direction of the oblique fissure results in an unexpected relationship between lobes and surface anatomy. The anterior surface of the right lung is composed of the right middle and upper lobes, while the anterior surface of the left lung is composed of just the left upper lobe. Meanwhile, the posterior surface of each lung is primarily composed of the corresponding lower lobe. This has important implications both when interpreting physical exam findings and radiographic studies like chest X-rays and CT scans. Each of the five lobes is further subdivided into bronchopulmonary segments, which are functionally independent units, each supplied by its own airway branch called a segmental bronchus, and its own branch of the pulmonary artery called a segmental artery. There are typically 10 segments total in the right lung, and either 8 or 10 total in the left lung, depending on the classification system used. The specific names and locations of each segment are beyond the scope of this series, but identification of each is important during thoracic surgery, as the functionally independent segments are surgically resectable units that can be removed with minimal impact on the remainder of the lung. The identity of each bronchopulmonary segment is also centrally important during bronchoscopy, a diagnostic test in which a flexible camera is introduced from the mouth into the airways, as each segment can be accessed by a specific dedicated branch of the airway tree, like navigating roads on a map. At this point, let's consider the path air takes as it enters the respiratory system. That journey begins upon entrance through the nose and mouth, passing through the upper airway, which consists of the nasopharynx, oropharynx, and larynx. In addition to being a conduit, the upper airway heats, humidifies, and filters inhaled air. Once air passes from the larynx into the trachea, colloquially known as the windpipe, it encounters the lower airway, which consists of a progressively branching network of smaller and smaller passages. As the trachea descends into the chest, the first branching that's encountered occurs at a structure called the carina, where the airway bifurcates into the right and left main bronchi. These two main bronchi are not symmetric. Although it's not shown in this diagram, the right main bronchus is wider and oriented more vertically, which is why most aspirated foreign bodies end up in the right lung rather than the left. These main bronchi enter the lungs at a lung structure called the hilum. The hilum is the wedge-shaped gateway on the medial surface of each lung, where in addition to the bronchi, pulmonary blood vessels, lymphatics, and nerves all enter and exit. It is both the anatomic and functional connection of the lungs to the mediastinum, facilitating the transport of air, blood, and lymph. Once the right and left main bronchi have entered the lungs, they continue to branch into progressively smaller airways. First into lobar bronchi, going to each of the five lobes, then segmental bronchi going to each of the bronchopulmonary segments, as recently mentioned, and so on and so forth. This branching continues for approximately 23 generations of segmentation, creating an intricate tree-like structure down to a microscopic level. This results in the massive upscaling of the area of the gas-exchanging surface. As a consequence, the distal end of the airway tree has a total area many orders of magnitude greater than the cross-sectional area of the trachea. The airways of the lung are divided into a conducting zone, responsible for the transport of air, and a respiratory zone, responsible for gas exchange. As the air present in the conducting zone at the end of inspiration doesn't participate in gas exchange, this volume is called the anatomic dead space. At the end of the line in the respiratory zone, at the final generation of airways, are microscopic sacs called alveoli, where the diffusion of oxygen and carbon dioxide between air and blood occurs. I'll talk a lot more about the alveoli when discussing histology in the next video. Moving back outward, each lung is covered by a thin membrane called the pleura, which is folded in on itself at the hilum to form two distinct layers. The inner layer, immediately adjacent to the lung, is called the visceral pleura, shown in green. The outer layer lining the chest wall, diaphragm, and mediastinum is the parietal pleura, shown here in blue. The potential space between these two layers is the pleural space. Under normal conditions, the pleural space contains only a tiny amount of fluid, typically not visible on routine imaging. This fluid is normally continuously produced and reabsorbed by the parietal pleura. While the volume of fluid is very small, the pressure experienced by that fluid is critically important during the respiratory cycle, which we'll get to when we start talking about physiology. In addition, the pleural fluid also acts as a lubricant to allow the two layers to easily slide past each other during inspiration and expiration. Although there is normally just a small amount of fluid between the visceral and parietal pleura, various pathologies can occur which drastically increase the volume of this space. For example, an excess of fluid within the pleural space is called a pleural effusion, as can be seen in this chest X-ray. Bleeding within the pleural space is called a hemothorax. Air in the pleural space is a pneumothorax, and pus within the pleural space is an empyema. All these processes compress adjacent normal lung and cause shortness of breath via multiple mechanisms. The parietal pleura is richly innervated by somatic nerves and is highly sensitive to pain, while the visceral pleura is innervated by autonomic fibers and lacks pain sensitivity. Moving to the pulmonary vasculature, the lungs have a dual blood supply. The primary pulmonary circulation carries deoxygenated blood from the right ventricle through the pulmonary trunk, which divides into a right and left pulmonary artery. These vessels continue to progressively divide, ultimately forming the dense capillary network that surrounds the alveoli. After gas exchange, oxygenated blood returns via the pulmonary veins to the left atrium. Pulmonary arteries, nerves, and lymphatics travel alongside bronchi and structures called bronchovascular bundles. Pulmonary veins generally travel separately. In addition, there is a separate, tiny volume bronchial circulation that runs in parallel, or more accurately, anti-parallel, to the main pulmonary circulation. Let's take a look at a schematic of the circulation to see why this quantitatively small amount of blood flow is relevant to physiology. This sphere will represent our right heart, that is, the combination of the right atrium and right ventricle. Leading into the right heart are the superior and inferior vena cava, which are returning deoxygenated blood from the rest of the body. Blood leaves the right heart via the pulmonary artery, with the pulmonary trunk branching into the right and left main pulmonary arteries before entering the lungs, where the blood is oxygenated in the pulmonary capillaries, before leaving the lungs via one of the four pulmonary veins and entering the left heart. From the left heart, the oxygenated blood travels to the rest of the body via the aorta. That's basic anatomy, which you are already familiar from our discussion a minute ago. But in addition to those great vessels, there are small, easily overlooked arteries that take oxygenated blood back to the lungs as part of the bronchial circulation. Some of these arteries branch directly off from the aorta, while some branch from an intercostal artery. Although the blood passing through these bronchial arteries only account for about 1% of the total cardiac output, these vessels are still important as they supply oxygenated blood to the lung tissue itself, primarily to the bronchi and larger bronchioles, and to the visceral pleura. Some of the deoxygenated bronchial blood drains to the SVC via several possible paths, while some drains into the pulmonary veins. The consequence of this is what is called a shunt, meaning a tiny amount of deoxygenated blood bypasses the pulmonary capillaries and enters the systemic circulation. In addition to this shunt involving the bronchial circulation, there also exists a tiny amount of intrapulmonary shunting that occurs in which blood within the pulmonary circulation either bypasses the capillaries or travels through a region of the lungs that have no ventilation, thus also bypassing the process of releasing carbon dioxide and bringing in oxygen. Not shown in the diagram are tiny veins called the Thebesian veins, which drain blood from the myocardium directly into the cardiac chambers, including the left ventricle. In young healthy adults at rest, these three shunts play only a minor role in physiology, contributing to a small difference between the partial pressure of oxygen between the alveoli and the arteries. This difference is known as the AA gradient, a topic to be discussed in later videos. Finally, as if this arrangement was not complicated enough, there are also small vessels that directly connect the bronchial arteries to branches of the pulmonary arteries prior to the division down to the level of the pulmonary capillaries. These vessels are believed to have no significance in healthy individuals, but also may have relatively minor physiologic relevance in chronic lung disease. The pulmonary lymphatic system plays a crucial role in maintaining fluid homeostasis in the lungs. Lymphatic vessels begin in the perialveolar interstitium and run along the bronchovascular bundles, in the interlobular septa, and in the subpleural space. These vessels drain interstitial fluid, proteins, and immune cells, ultimately returning this lymph to the systemic circulation via the thoracic duct and the right lymphatic duct. Breathing requires coordinated muscle activity. The diaphragm, which is the large dome-shaped muscle that separates the thoracic cavity from the abdominal cavity, is the primary muscle of inspiration. When the diaphragm contracts, it descends, increasing the vertical dimension of the thoracic cavity and creating negative intrathoracic pressure that draws air into the lungs. When the diaphragm relaxes, the internal inwardly directed elastic recoil of the lungs contracts them back to their resting state. Innervation of each hemidiaphragm, that is, each side of the diaphragm, comes from the ipsilateral phrenic nerves, which themselves originate in cervical nerve roots C3, C4, and C5. In addition to the diaphragm, the other primary muscles of inspiration are the external intercostal muscles, which elevate the ribs, expanding the chest wall laterally and anterior-posteriorly. During increased ventilatory demand, either during exercise or because of the need for an unusually high force to expand the lungs, in those cases, accessory muscles of inspiration are recruited. These accessory muscles include the sternocleidomastoid and scalene muscles. As mentioned, quiet restful expiration is typically passive. However, in active expiration, needed during exercise, coughing, or in cases of high airway resistance, expiratory muscles are recruited, including the internal intercostals and abdominal muscles. As to what regulates the use of our respiratory muscles, that's a complex topic to be covered in a future video. However, in extreme brief, it's a combination of input from the unconscious respiratory centers in the brainstem, central and peripheral chemoreceptors that respond to changes in arterial oxygen, carbon dioxide, and pH, mechanical and irritant receptors in the lungs, mechanical receptors in the respiratory muscles, and conscious voluntary control that can very temporarily override input from all of the others. I'll end with a summary of what I've discussed. The right lung has three lobes in upper, middle, and lower, separated by horizontal and oblique fissures. The left lung has two lobes, in upper and lower, separated by just the oblique fissure, with the lingula as a tongue-shaped projection of the upper lobe. Each lobe is subdivided into bronchopulmonary segments, which are functionally independent, surgically resectable units, each supplied by a segmental bronchus and segmental artery. The airway branches for about 23 generations from the trachea down to the alveoli, divided into a conducting zone for air transport, which is also known as the anatomic dead space, and a respiratory zone for gas exchange. The hilum is the medial gateway where bronchi, pulmonary vessels, lymphatics, and nerves enter and exit each lung. The visceral pleura covers the lung, the parietal pleura lines the chest wall, and the pleural space between them normally contains only a thin film of lubricating fluid. The lungs have a dual blood supply, the pulmonary circulation used for gas exchange with the alveoli, and the bronchial circulation used to perfuse the tissues of the airways and visceral pleura. The diaphragm is the primary muscle of inspiration, with the external intercostals assisting. Accessory muscles of inspiration, the sternocleidomastoid and scalenes, are recruited during increased ventilatory demand. Quiet expiration is passive, while active expiration recruits internal intercostals and abdominal muscles. And finally, controlled respiration involves unconscious input from brainstem centers, central and peripheral chemoreceptors, irritant and mechanoreceptors in the lungs, mechanoreceptors in the muscles, and voluntary conscious control that can override all the others, but only very briefly. Thanks for watching this video on the anatomy of the respiratory system. If you found it helpful, please like and share it with your classmates and colleagues, and feel free to leave a comment or question. The next video in this series will discuss the histology of the respiratory system.